Colonel Owen, so he's our dentist, and then our ophthalmologist, Major Hyman, will be teaching block 2 and block 3. Just to kind of introduce a little bit about myself, so I've been in for 16 years. I've been a PA for about 6 years. I know, right? I look young. I've been a PA for 6 years. What is this? Oh, are you just recording? Oh, I see. Okay, perfect. I've been a PA for about 6 years. Prior to listening, I was E5, switched over to Green Gold ADO. Gosh, what else? And then I was a logistician officer for about 5 years. I've been a PA for 6 years. Came through OPTAP in 2018. Just some of my academic background. I do have associates, 2 bachelors, 2 masters. I've done some research in epidemiology. I've done some non-traditional assignments, so the traditional like battalion PA, brigade PA, aide de camp stuff, so O5 Alpha. And then I recently completed my doctorate of medical science with a focus in placing PAs in concierge medicine. And I'm currently doing my PhD in health science. So moral of the story, never stop learning, just be a lifetime learner. That's enough about me. We'll kind of get into otolaryngology. All right, so for this class, right, this is probably, you guys are taking pathology, right, in radiology. So this is going to be one of the first courses where you take that knowledge that you learn and you have to apply it versus just rote memorization in freshman semester. Some of that information in freshman semester will be applicable in this class. So understanding big concepts is going to help you be successful within this course. Kind of went over this already, but exam 1 will be ears and nose. Exam 2 will be dental, oral, pharynx, and neck. And then exam 3 will be ophthalmology. Just to kind of give you some feedback on the breakdown of the exam. So exam 2 is going to have 50% of oral, pharynx, and neck, and then 50% of dental. And then the final exam will be all ophthalmology. Pay attention, this is 6% of the pants, and honestly, like when I was in family medicine, right now I'm in endocrinology, but when I was in family medicine, probably about 50% of my patients came in with the HEENT complaint. So like this is our bread and butter as a primary care PA, and then you can go on and do greater things, but just kind of get the basics down. All right, these are your references. So current medical diagnosis and treatment, both for 2025 and then the otolaryngology version. If you want to get more in depth of the different pathologies and disease processes that we're talking about, these will be your references. But for the test and for the course, your main source is going to be the slides. So that's what we'll be using as the slides. Kind of highlighted this already. Chapter 8 is about 100 pages. I know you guys are under like accentuating circumstances, like with your time crunch and everything. But if you do have time, like take a delve into current. Like I said, this is bread and butter stuff, so it's not going to go away. Just kind of going over some of the anatomy of the slide. So we'll go over like the disease and condition, and then you'll see the objective. And then at the bottom, so it'll say pants topic. So that's your clue that it's high yield on the pants, and also it's going to be high yield on the test. So we'll use the syllabus, so the syllabus is all encompassing, but the pants blueprint is what I'm testing you on, because that is what you're going to have to test on at the end of the day. Like that's how you get your certification. So I focused the test on pants topics. So if you don't see that pants topic indicator at the bottom, maybe just don't spend too much time on that topic. You can, if you're interested in it or you have any questions, we can go into it individually, or you can do some reading on your own. This is our course terminal objective. I won't read over that, just take some time to read that over. So the enabling learning objectives, I do recommend that you read over these, because then you will understand why we are learning the information in the class, like why we are going over these different disease processes, or if we're just going over some anatomy, basic concepts, etc. Do I have a pointer now on this one? Yeah, this one. Okay, so, just kind of being transparent, so I don't test directly on anatomy in this class, because you've already taken AMP 1 and 2 and passed. But some of the things that you will see within the vignettes of this course is anatomy, and it'll kind of help you clue in on the correct answer. So specifically for the ear, we'll kind of go into, oh, it's not great. Anyway, so just starting with the oracle, right? So oracle, the purpose of this slide is to show you how sound is conducting through the ear. Because if you understand where the pathology is within that middle ear, we know that sound is not correctly conducting. So ideally, sound will whether it's my voice or you're taking a hearing test, sound will be released and conducted from the external auditory canal to the middle ear, to the inner ear, to the brain, right? And then some key concepts here is like that tympanic membrane, those ossicles or that ossicular chain, so the malleus, incus, and some people pronounce it stapes or stapes, but I pronounce it stapes. You can see how close the eustachian tube is in relation to the middle ear, so that's all one entity. So that's the eustachian tube, so we have to make sure that that's properly functioning down here. And then lastly, in the cochlea. So in the cochlea, that's where the nerve tracts are located, right? So that's where we have the vestibular cochlear nerve, and then I'll show you some other anatomy where the facial nerve is right here. The facial nerve is really in close relationship with the vestibular cochlear nerve. All right, so hearing loss does not mean complete deafness, right? We'll talk about some hearing loss classifications. There are two different types of hearing loss. So conductive hearing loss and sensory neural hearing loss. For conductive hearing loss, the pathology, the issue is either in the external auditory canal or the middle ear. So it's something going on, and we'll talk about this in later lectures, but it's something going on that's impairing the sound being conducted from the auricle to the external auditory canal, to the middle ear, to the cochlea, from the cochlea, that nerve to the brain. So it's something, but the pathology is in the external auditory canal or the middle ear. For sensory neural hearing loss, so it's one type of hearing loss because it's very difficult to distinguish these two. But if it's sensory, then there's something going on within the cochlea. So the cochlea contains the nerves. So the vestibular cochlear nerve, or if it's neural, it's going to be some deterioration of the nerve tract. So that cranial nerve 8. All right, hearing dysfunction types continue. So if a patient presents to you with hearing loss, we need to get an audiogram, right? I know that's very vague, but just introductory. One exception to this is going to be if a patient presents to you and you can correct their medical condition in your clinic, right? So, for example, if a patient comes in, they say, hey, they might not say I have hearing loss. They may say like I have muffledness, or I just can't hear as great, or I noticed I turned the TV up louder, or whatever the case is, right? So they're not going to explicitly tell you they always have hearing loss. That is going to be our indicator for when we need to do an otoscopic exam. When we do the otoscopic exam, if we identify a cerumen impaction, one of the things you can simply do is irrigation in the clinic. So if you irrigate the patient's ear, their hearing becomes normal. You don't need to go and get an audiogram. Does that make sense? A little bit? Okay. Same thing with, and I know we're kind of talking about some terms that we will discuss the pathology later on, but it's very important that you kind of understand this concept initially. And then going into same thing like with acute otitis media, right? So we can treat that with antibiotics. If we identify based on the patient's HPI, their signs, symptoms, physical exam, that we can prescribe antibiotics and treat acute otitis media, then we don't need to get an audiogram, right? Because we can treat that patient. Those are just two examples. All right, can I get, and then we'll go over this as well, just to kind of hit the nail on the head. Can I get a volunteer just to read this out loud for me?
41-year-old male presents the clinic with increased hearing and a sensation of fullness in the right ear. Otoscopic exam reveals complete cerebral impaction obstructing the external auditory canal. Based on the patient's presentation, you do not suspect a tympanic membrane perforation. What is the most appropriate next step in management for this patient?
Perfect. Okay, thank you. So let's kind of break this down, right? So we have a 41-year-old presenting in clinic with decreased hearing. We perform an otoscopic exam and we identify cerumen impaction, right? So this is a key point though. So in the vignette, we know that we can assume that it's no TM perforation, right? Because that's going to be important for our treatment. How can we assume that? So in the HPI, if you were in clinic, so let's step out of academia for a second. If you were in clinic, you would ask the patient, have you recently had exposure to barotrauma, i.e. diving, skydiving, any explosions, were they trying to clean their ear with a hairpin and their hearing loss started when they were cleaning their ear. So you have to kind of get into the nitty gritty, but in a vignette scenario, I have to let you know that the TM is not perf because you're not going to be able to see behind the cerumen impaction, right? Does that make sense? So you do your otoscopic exam, and then you do not suspect the TM perforation. I really want to drive that home. What is the most appropriate next step in management for this patient, right? So A, immediate systemic antibiotics, not really presenting like he has an infection, referral to otolaryngology for an audiogram. So we can do something else besides just referring them directly out because we've identified the cerumen impaction. Topical corticosteroid drops, not even applicable, and we'll talk about this. Surgical merinotomy, not applicable. And then ear irrigation with warm, just write the W in, warm water or saline. So that's going to be our most appropriate next step. These are just some statistics for sensory neural hearing loss so you understand the population that you're dealing with. So you can see, like, ideally it's elderly, 30 to 35% of patients are over 75, 40% are over 65, 40% are over 75. Okay, so getting into some audiology and hearing conservation terms. So pure tone audiometry. Everybody has had a hearing test. Most Army, I'm pretty sure Air Force, you guys are required to have a hearing exam annually, is that correct? Depends on the job, okay. Do you have any Coasties or, no, this is only Air Force and Army, okay. So what's happening in pure tone audiometry? Oh, do we have one? Oh, Marie, oh, how are you? Oh my gosh, you just kind of like, yes, it's okay, you're here. It's the tan t-shirt, that's what it is. It looks green because the lights are off, but I get it. Mama room, I'm here. Okay. So, in pure tone audiometry, so what's happening is the patient's hearing is being assessed at different frequencies. Those frequencies are measured in hertz, right? So 250 hertz is associated with the lower tone, whereas 8,000 hertz is going to be associated with a higher tone. Okay, the hearing level, which we'll get into the audiogram, is measured in decibels. So the frequency is measured in hertz, the hearing level is measured in decibels. An audiogram can detect air conduction and bone conduction, but ideally it's only used for air conduction. If for any reason you need to include bone conduction, that's like definitely a referral to otolaryngology. Like that's way out of our scope. So this is an example of an audiogram, kind of just what I was talking about, like the x-axis, you can see the different frequencies from 250 to 8,000, and then the hearing level is measured in decibels. They can do, if you look at the key at the bottom, they can do what's called masking. So again, this is going to be an HEENT referral, or audiology, if they need to mask the ear, so they're basically putting a consistent sound in one ear to measure the solidarity and of the left ear to make sure that they are isolating that ear to measure its hearing. But again, that's like audiology, otolaryngology stuff. Has everybody seen an audiogram before? No? Okay. Kind of like typically what you, oh, did I go too fast? Yes, I did. Oh no, we'll talk about it later. So this is a graphical depiction of an audiogram, but it can be also on a printout. So for tympanometry is a test used to measure the middle ear function. So middle ear function is, we're thinking about going back to our anatomy. So the movement of the TM, the movement of the ossicular chain, right? Is it fluid in the middle ear? Is it negative pressure in the middle ear? Because remember the eustachian tube is also located there. So we can use tympanometry to identify pathology in the middle ear. Why do we need this? Because we cannot see behind the tympanic membrane. So when we're doing an otoscopic exam, you can only see the external auditory canal. And we'll kind of get into this. Another type of test is speech discrimination testing. So this is, again, a referral to audiology or to otolaryngology. The patient is presented with different words, and the patient is asked to identify the words. A normal score is going to be between 90 and 100%. Low score will be less than 90%. So for this test, this is going to be important in referring a patient to audiology or ENT for a cochlear implant or hearing aids. Thing is, so with hearing aids, if you think about, the patient has to be able to distinguish between words. So if their score is not between 90 and 100, if they cannot distinguish between love and cell, right? If we give them a hearing aid, it only increases the sound. So they will hear love, cell, boom, boom. So it'll just be muffled, but just increase, the sound just will be elevated. A hearing aid does not help with a patient discriminating words or being able to detect what words are being said. It only helps with either increasing sound or decreasing sound. Let's see. So this is our hearing loss classification chart. Biggest thing is knowing our normal. So our normal is between 0 and 20 decibels, and then mild, moderate, severe, profound, etc. But know the normal. All right, audiograms and tympanograms. So going back to pure tone audiometry, so it's conducted in a sound booth. If you've had an audiogram, you've probably been in the individual or the group sound booths. So what's happening is when we put the headphones over our ears, that sound that's being released is detecting air conduction. Like I said, they can detect bone conduction, but that's usually advanced. Typically, it's just air conduction. The results are depicted on the audiogram, which we already kind of went over, where it shows the ear being measured at different frequencies, and the hearing level is measured in decibels. This is just an example of a normal audiogram. Again, just kind of really bringing it home to x-axis is frequency, and then the y-axis is the hearing level. What's our normal hearing level? 0 to 20. All right, so this is the other printout that I was referring to. So this is also an audiogram. You may have seen this as well. It's just not a graphical depiction of an audiogram. It's a printout. But you can still see, what happened? Oh, there we go. You can still see like where the frequency is located in the left ear, right ear. Those are like the most applicable things for us, like that AB 512, and I don't even know what that stuff is. That's going to be the audiology stuff, so don't worry too much about that. All right, hearing conservation data form. So the audiogram, usually the printout or the graphical representation, is transferred onto the hearing conservation data sheet form 2005. I think this is tri-service because it's Army, Navy, Air Force, and Marine at the top. Essentially, what's happening is that audiogram is transferred here. You can see audiogram date, left and right ear. And then ideally, the patient will have a baseline. That's that reference audiogram date, and then this second line here. And if it's any threshold shift, that'll be depicted on there for you as well. Is it any on this example? 10. Because a threshold shift is usually greater than 20, so no, it's not. Greater than 20 change in decibels. All right, check on learning. What diagnostic tool is used to assess middle ear function? Tympanometry. All right, how are we feeling? So we're about, I think we're like 20 slides in? 22, 26, so almost halfway. Do we want to take a break? Do you guys have caffeine? Charlie mic, okay, perfect. All right, so tympanometry. So I will again be transparent about this. Tympanometry is going to be performed by an audiologist, or it's going to be performed by an otolaryngologist, right? So these are referrals to audiology and HEENT. But just so you understand the purpose, tympanometry is usually conducted in conjunction with the audiogram. So remember, we can use it to assess middle ear function, seeing if there's any pathology in the middle ear, because we cannot see beyond that tympanic membrane. Ideally for this test, so listen up closely because this can get very confusing. So normal air pressure is 0. So that's room air pressure in tympanometry. Now I'm not talking about like PSI 14.7 pounds per unit or whatever the measurement is. That's not what I'm talking about. In tympanometry, normal is 0. What we can assume in tympanometry is if in the external auditory canal, if it's 0 decapascals, then it's going to be 0 decapascals in the middle ear. So we want 0 on both sides of the middle of the tympanic membrane. That's how we know it's no pathology. Check the box. This test is very quick and simple. It takes like 5 minutes. So that's why they use it in conjunction with an audiogram. Now what happens with the test is a probe is inserted into the patient's ear. It's creating a vacuum. So going back to that 0, 0 on each side of the tympanic membrane. So the probe has 3 functions, 3 small holes, 1 hole, and all of these are being conducted simultaneously. So the first hole is releasing a continuous sound. That's air, that sound being conducted down the external auditory canal to the middle ear, to the inner ear, from the inner ear to the brain, right? So that's happening. The second thing that's happening is air pressure is being released. So that air pressure is going to change from negative air pressure to 0 air pressure to positive air pressure. So they're trying to see at what air pressure does sound conduct the best down the ear. That's the whole purpose of tympanometry. And then the third thing is going to be, it's an air pressure monitor. So if it is pathology in the middle ear, then sound is coming back. Ideally, sound won't come back because we want all of this sound to be conducted to the brain, essentially so you can hear. But if sound is being conducted back, for example, at negative 200 decapascals, we know that it's negative pressure built up in the middle ear because that's the best pressure that sound can be conducted. But we want 0 and 0, even Steven, on both sides of the tympanic membrane. I know that's a lot, but that's kind of the summation of it. And there's some notes in there if you guys want to revisit this too. Any questions on that? Okay, not right now. And then just kind of recapping this is such a good picture because it just go back to this when we start talking about the condition, the diseases, pathologies, because then you can understand the anatomy and know where the dysfunction is. So just kind of reiterating this picture here. So in tympanometry, similar like audiometry, a tympanogram is produced after a patient undergoes tympanometry. So on the x-axis, that's the pressure being released from that probe in decapascals, and then on the y-axis, that's the middle ear compliance. So I'm not just talking about the TM, I'm also talking about the ossicles. So you see how the malleus is connected to the TM? So all of that is required to function properly for sound to be conducted properly. So like, not just the movement of the tympanic membrane, but those ossicles also move very slightly, but they do have some movement to conduct sound from the stapes to that oval window. So all of that stuff is important. And then this is just a normal tympanogram. Units of measurement, cubic centimeters cubed, and then decapascals is our measurement for the pressure. Sorry, I missed one thing. Normal compliance, so normal middle ear compliance, and we'll kind of go over this, but I want to drive it home. So normal middle ear compliance is between 0.2 and 1.8 cubic centimeters cubed, right? So if we're in that range, that's the ossicles moving normally, that's the tympanic brain moving normally, that's the stapes moving normally on the oval window. So all of that is normal as long as it's in between 0.2 and 1.8 cubic centimeters cubed. All right, so this is, any questions on that before we get into going over a tympanogram and then going over an abnormal tympanogram? No questions? Okay. Yes, sir.
So if this graph is shifted left or right at peak,
Mm-hmm.
then that's like, then you're talking like not normal conduction.
Absolutely. I'm just gonna repeat your question just so everybody can hear it, not to embarrass you or anything. So his question was, is if the peak, so the 0 shifts left or right, does that mean that it's abnormal pressure in the ear? The answer is yes. Yes, so that means, so normal is 0 plus or minus 100, right? But if we get if we get to 150 or 200 range of decapascals, that's, whether it's negative or positive, that's abnormal. We want to stay at the 0 and plus or minus 100. So type A normal tympanogram, this is just an example, kind of just going over what we already discussed. So 0 decapascals of pressure. The middle ear compliance is at between 0.2 and 1.8 cubic centimeters cubed. All right, plus or minus 100 on the decapascals. So we know intact TM. We know the eustachian tube is functioning normally, right? Because the eustachian tube is connected to the middle ear. And we also know that the patients, if they are presenting with hearing loss, it's not in the external auditory canal or the middle ear. It has to be some pathology in the cochlea, which is a part of the inner ear. So we'll get to that. Again, I love this picture so much because I think it just does a good job of really highlighting some of the important anatomy. All right. Water. You guys still doing okay? Any questions on a normal tympanogram or just the concept of tympanometry in general? All right. All right, so this is our first abnormal tympanogram, right? So here, the issue is the compliance is not between that 0.2 and that 1.8 cubic centimeters cubed, right? So we still have normal pressure, but the compliance is not there. So remember we're talking about the ossicular chain, the TM as well. So this is often associated with ossicular fixation, otosclerosis, or TM scarring, and we'll get into these pathologies. Don't worry about it too much here. We'll talk about these in depth. But just understand the concept of that TM is too stiff. It's not moving correctly. The ossicles are too stiff in the middle ear. They're not moving correctly. So we don't have that compliance on the y-axis. The pressure is normal, so the decapascals are good, but it's just the middle ear compliance. Next abnormal tympanogram is type AD. So this is where we have too much compliance. So here on this example, you can see where it's still, the pressure is still normal, right? It's plus or minus 100 decapascals, but the compliance is too much movement. So the ossicles are moving too much, the TM is moving too much. This can be secondary to the ossicular disarticulation or acicular chain discontinuity. So type B flat, two things can happen in a flat tympanogram. So either one thing, the patient has a perforation, so when we put that probe in the patient's ear, nothing can be conducted, right? Like the machine cannot bounce off of a perforated TM for the TM to send sound to the ossicles, to the inner ear. It's just a big hole. So the peak in the compliance is kind of just going to be all over the place. It's just flat. The other thing that can happen is too much pressure, too much fluid in the middle ear. Same thing. So it's such a small and confined space. If you put any amount of fluid in there, the TM is not going to be able to move. The ossicles are not going to be able to move. So it's just going to be flat. Too much pressure. I think it's 200 or plus decapascals. And then I think this is our last one, is type C. So this is going to be a retracted, type C retracted tympanogram, or so the TM is retracted, or a eustachian tube dysfunction, or both. Because if the eustachian tube is not opening and closing correctly, then it can be pressure buildup in the middle ear, causing that negative pressure buildup. So here you can kind of see where the pressure is closer to negative 200, so it's probably like at negative 175. Our compliance is normal, but we have that negative pressure buildup in the middle ear. All right, let's take a quick break. Like, how are you guys feeling? Good, okay. No break? All right, okay, let me just set this aside. Oh, good, okay. All right, so going back to conductive hearing, and if you need to use the restroom or something, just go ahead. Going back to conductive hearing loss, so causes, we kind of went over this already because I tried to make it applicable to the graphical depictions that we're looking at. So we went over an obstruction. So an obstruction, cerumen impaction, also a foreign body can cause some conductive hearing loss, because remember the pathology is going to be in the external auditory canal. Mass loading middle ear effusion, so we're in the middle ear, whether it's a buildup from secondary to acute otitis media or otitis externa, acute otitis media in the middle ear. Excuse me, sorry about that. Stiffness or otosclerosis, so that's where the acicular chain is not moving correctly. Discontinuity, so the acicular chain and malleus incus and stapes are not touching the way they need to conduct sound. Or tympanic membrane perforation. Again, we're in that middle, we're either in that external auditory canal or the middle ear. That's where the pathology is, and the patient has conductive hearing loss, or some disruption there. So clinical presentation is going to depend on the cause, so the different causes that we just went over. So what is a cause of obstruction, or what are one of the causes of conductive hearing loss? Jelly bean in the ear, cerumen impaction. What was that? Perforated TM, absolutely. Yep, all great examples. Key thing here, so we're going to have to get a good history. So is it a child that put a jelly bean in their ear where they're playing with Legos, or I don't know what kids play with, but those small little toys? When did the hearing loss start? Is it progressive? Is it gradual? Is it unilateral, bilateral? Do they have associated vertigo, tinnitus, so that's buzzing, popping, clicking within the ear? All of these things matter, so we have to make sure that we get a good HPI. Evaluation, so regardless of if it's conductive hearing loss or sensory neural hearing loss, we don't know when the patient presents. We just know that they have hearing loss, or it's muffled disc, or mom said a jelly bean was in the ear, whatever the case is. So we still need to perform an otoscopic exam. What that consists of is we're still going to inspect the auricle, the external auditory canal, the TM, right? We want to inspect the TM to make sure it's no masses, bulging, perforation, if it's any discoloration. looking at some of the landmarks, so that pars tensa and that pars flaccida and the light reflex, just making sure that we can see normal. All right, conductive hearing loss. So we're still in the evaluation part, right? So what we're about to go over are 2 tests that you can do as a primary care PA, as a PA in clinic, right? So we can do the Weber and the Ryan, some people pronounce it Renee test. Okay, can I get a patient or a volunteer really quick? Oh, perfect. All right, so, well, let's stand, I think it's probably easier if we stand this way, yeah. All right, so we're going to assume that this patient has normal hearing, no issues with hearing. Okay.
Just, we'll see.
We'll see, okay. So in a normal Weber test, right, what we do is we take, have you been exposed to like the tuning fork? You've had some pen skills, right? Okay, so we take the tuning fork and we flick it to elicit sound, right? In a normal Weber, we're gonna place it on the mastoid. Some providers place it on the nasal bridge. I usually just do the mastoid. And we ask the patient, in which ear do you hear the sound the loudest? Oh, sorry.
Right here, probably.
So, ideally, normal. Normal means it's louder.
It was like equal. Is it too much? Is it equal?
It wasn't equal, be honest, because it's not, okay, perfect,
I didn't know if I was
okay.
supposed to hear one side more or not.
Okay, it's just.
Tell me the right answer. Tell me the right answer.
For example,
It's equal, people.
somebody with normal hearing. Okay. Somebody with hearing, okay, sorry about that. So thank you. So ideally, this patient would have a normal Weber would be the patient hearing that sound in each ear equally, right? So that's a normal Weber test, right? Now, getting into conductive hearing loss. If we have a positive Weber for conductive hearing loss, the sound is going to lateralize, be louder in the affected ear. So can I get another patient? So this patient, is it Litton? Okay, so what's your first name? Dakota. So Dakota, he presents to the clinic with right ear muffling or hearing loss, right? I perform my Weber test. And you're gonna hear it louder in the right ear. Where do you hear? In the right ear. Okay, thank you. So the sound is going to lateralize in the affected ear. Okay? That is a positive Weber test. Renee or Ryan, so bone conduction will be greater than air conduction. So in a normal Ryan test, well, let me go back. Any questions on the Weber test, whether normal or abnormal in conductive hearing? Abnormal as it will be in conductive hearing loss. Yep. That's affected. Yes, so if the patient comes to you right ear muffling, hearing loss, that is where you're going to hear the sound the loudest, is in the affected ear. Yep. Okay, any other questions on the Weber test? Yep. Yes.
So when you say the Weber test is negative, that means it's normal?
No, we use terminology positive Weber, or if it's a normal, if the Weber is normal, it lateralizes to both ears equally.
So when you say Weber test is
Positive for conductive hearing loss.
that means they have one, or the hearing's affected in one ear when you say positive?
In the affected ear. So patient is presenting right ear, I'm presenting with right ear hearing loss. I perform the Weber, I hear it louder on the right side. And that's a positive Weber for conductive hearing loss. Yes, sir.
What's the reason? Like, why is it louder in the ear that's
Yeah, no,
having hearing loss?
great question. So remember kind of going back to sound conduction. So because it's an obstruction in the external auditory canal, it's like the brain can process sound better when it's air conduction, right? But if you have an obstruction, more of the sound is gonna lateralize through that obstruction. So think about it like you have an extra piece in the ear to conduct sound down to the inner ear. Does that make sense? So like the jelly bean.
It's almost like it can't escape the ear canal. It's like kind of just that sound's getting stuck in that affected ear.
In the
and it just
affected
keeps
ear.
loud,
Jelly
loud,
bean,
yeah.
yep, jelly bean in the right ear. Yes, perfect. Okay. Any other questions? So we can still, hold it down, guys, hold it down, hold it down. So we have, so her question was, if the patient has bilateral hearing loss, is it a benefit in doing the Weber test? So ideally in practice, absolutely, you'll still do the Weber, you'll still do the Rhine, but you still have to associate the HPI, right? So we'll talk about this later on, but for example, presbycusis, they will have bilateral hearing loss. They won't say like, oh, I have bilateral hearing loss. They might say, I turn up the TV louder, or I play an instrument and I just can't hear it as well anymore, or something to that effect. So yes, I still recommend that you perform the Weber and the Renee, because we're doing an evaluation to see what's the cause of the patient's hearing loss. Yes, sir.
So, ma'am, then how do you know if it's positive? Because with loss, you're able to hear both, and it's just louder, or I don't know.
So kind of going back, so his question was, how do we know if it's a positive or negative Weber if the patient has, can you hear me over here? Okay, if the patient has decreased hearing in both ears, that's going back to the HPI, right? Because this is a good test. These are tests that we can use in clinic. This is not the end all be all. So say that the Weber and the Rhine is normal, but the patient is still like, yeah, I just really don't think I can hear as great. Let's send them for an audiogram. Let's send them for a tympanogram or a tympanometry. So this is not the end all be all, because in presbycusis and bilateral hearing loss, the Weber will be normal. Because they will have that hearing loss in both ears. It might not be the same degree of hearing loss, but they may have some bilateral hearing loss in both ears.
So, if we take out the HPI, can you just assume then that it was normal, and then knowing the HPI, then obviously like send them, refer them, or would you automatically just say because of how they presented or their story that they told you, and then I guess like what the result was, then that it was abnormal, you just assume it was abnormal, and then just
Yeah.
so I mean, you really can't tell a difference if it's louder than one ear, both of the ears are affected, right?
Absolutely. So medicine is not to a singular test, especially one that we're doing in clinic. So you can't just say, oh, the Weber and the Rhine is normal. You have to tie in the HPI, because you have some simple tools. You can send them to get an audiogram. You can send them, and we'll talk about unilateral hearing loss too, but you can send them to get a tympanogram. So if your Weber and Rhine is normal, that doesn't mean it's the end all be all. You still have to tie in the HPI, and then that's where the vignette questions come in. So I have to let you know in the vignette, is the Weber, either give you an audiogram showing decreased hearing loss, give you the results from the Weber, from the Rhine test. So it all ties into a vignette. Yeah, it's like this one test is not the end all be all. Does that make sense? Okay. Any other questions? All right, so we got Weber covered. So Renee or Rhine, so the Renee or Rhine test, so in a normal Renee-Rhine test, air conduction is going to be greater than bone conduction. Ideally, the inner ear can perceive sound better with air conduction as opposed to bone conduction. If we know if bone conduction is greater than air conduction, it's something that's allowing it to lateralize into some pathology, whether it's a jelly bean, whether it's fluid, something is causing the sound to lateralize on the affected ear. So bone conduction should not be greater than air conduction. AC is always greater than BC. Okay? So for example, in the Rhine test, we'll just kind of go over normal. Can I get another patient? Oh, yes, sir.
You said AC is greater than BC, but on the slide it said BC. Can you just flip up?
That's normal.
Okay.
Yep, so normal is AC greater than BC, air conduction greater than bone conduction. Abnormal, which I'm about to go over, is bone conduction greater than air conduction, and we will see this in conductive hearing loss. All right, let me get another case. Okay, let's go. What's your name, first name? Casey, okay, perfect. So, patient presents with right ear, or let's do left ear hearing loss, okay? So, in the Renee test, what we will do is we will start with the tuning fork on the mastoid, right? And then you're gonna ask the patient to tell you when they stop hearing the sound. When they stop hearing the sound, you take the tuning fork and you place it a couple inches away from the ear. They should still be able to hear the air conduction, ideally. Air conduction should be greater than bone conduction. If she says, no, I cannot hear the air conduction, then that means that's a positive Renee test. So bone conduction is greater than air conduction. So our patient is presenting with left ear hearing loss. I'm going to perform the Renee test. So what we do is we place this on the mastoid. So I'm just going to ask you when you can no longer hear the sound, just let me know, okay? Can you hear it? Okay, just let me know when you can no longer hear it. Can you still hear it? Okay, perfect, patient. Thank you so much. So in that patient, she could still hear air conduction greater than bone conduction. That's normal. In conductive hearing loss, bone conduction is going to be greater than air conduction. That's a positive Rhine test. That's how we know it's some abnormality going on. Any questions on Weber or Rhine or Renee? Okay. How are we doing on time? 8:47. Okay. All right, so kind of like one of the students had a question, so is this the end all be all? No, Weber and Renee test, we can use these tools to assess patients in clinic. Other evaluation techniques or diagnostic tools that we're going to use for conductive hearing loss is going to be an audiogram or a tympanogram, tympanometry or audiometry. We have to refer these out to audiology and HEENT or otolaryngology. So treatment, again, it depends on the cause, the underlying cause of the conductive hearing loss. So if it's obstruction, secondary to cerebral impaction, we can do irrigation. If it's a foreign body, and we'll get into all of these, this is just like introductory, just remember we're in introductory. We'll get into the specifics of each one. We can remove that foreign body, a fusion if it's otitis externa, if it's otitis media, we can treat via antibiotics. And then some patients will need a tympanostomy, so those are the ear tubes. Stiffness, we can treat otosclerosis with a stapiotomy, so that's the prosthesis of the stapes. Again, that's a referral to HEENT, and then a TM perforation. So just, you can write this in, but I think your slide says tympanostomy, but the treatment for a TM perforation is, or spontaneous, TM perforation is either spontaneous repair, so we can let the patient repair, TM repair on its own, or we can do marsupialization. So the treatment for a perforated TM are two things: spontaneous repair, so allowing the patient's TM to repair on its own, because it will do that, or we can do marsupialization. That's when they perform a small cut in the tympanic membrane. And then depending on the pathology, they will sew it back up. All right, let's take a 10-minute break, and then we'll get into sensory neural. Yeah. Oh, sorry. Oh, sorry. So right at 09, we'll get started.
you stop hearing here, should you still be should you like and just get but then again,
Maybe to have something blocking and maybe room and capacity.
Trust me, we should. Yeah, 'cause you have.
speak and then you say it all different. Yeah, but every conversation is it's like it's recorded. Yeah, and that's the benefit. Like there's a lot of things that come online. It's not a lot because it's
There's a lot more slide.
Alright, let's go ahead and get started at 9:02. Sorry, just having some technical difficulties here. Alright, I think we were here at sensory neural hearing loss. So any questions on the material that we've covered so far? And I just encourage you to ask questions, because if you're thinking it, probably someone else is thinking it. So I'll try to repeat the question if I remember, and that way everybody can benefit from the question. So, all right, so sensory neural hearing loss. So we kind of talked about this a little bit already. So the dysfunction is going to be in the inner ear. So it's either cochlear dysfunction or dysfunction in cranial nerve 8 and the sensory and the vestibular cochlear nerve. Specific causes for sensory is deterioration of the cochlea, presbycusis. So that's most common cause of bilateral sensory neural hearing loss. So we had some questions on this. So yes, this is usually going to be in our older population. Patient may present with they might not tell you I have hearing loss, but I just can't hear as great. Maybe I'm turning the volume louder on the TV. Maybe I'm turning up the musical instrument. Maybe I need to turn my music up louder and I don't like it. Or my wife can't hear me, my husband can't hear me as good as they used to. Whatever the case is, you have to associate that. And that could be presbycusis or bilateral hearing loss. Other causes can be noise trauma, head trauma, or systemic diseases, which we'll talk about in depth in future lectures. Okay, causes of neural. So remember sensory neural. We went over causes of sensory. So this is deterioration of the nerve tract, secondary to lesions. So an acoustic neuroma. So this presents usually I would say usually because I have some patients with bilateral acoustic neuromas, but usually patients have a unilateral sensory neural hearing loss. What's going on here in an acoustic neuroma, and I won't get into too much of the detail because we'll get into it in later lectures, but the myelin sheath is accumulating and a mass is developing on that cranial nerve 8, causing that acoustic neuroma. So the patient will present with unilateral hearing loss most commonly. Multiple sclerosis, so that autoimmune disease where the body is attacking the nerve sheath, right? And then auditory neuropathy can also be a cause of sensory neural hearing loss. We'll get into these conditions and diseases in further lectures. Again, so same as conductive hearing loss, the patient is going to present based on the cause. And so it's going to vary, right? I can't tell you they're exactly going to present like this, but as we go through the pathologies, you will see how patients present and some of the most common associated signs and symptoms to look for on a physical exam. History is extremely important, like we talked about, onset, duration, unilateral, bilateral associated symptoms, etc. Evaluation, we're still going to do the same evaluation as if a patient had conductive hearing loss, because at this point with the patient presenting to you, we don't know what type of hearing loss it is. We just know that the patient has some type of hearing loss, and we have to evaluate them to determine that it is sensory neural hearing loss. That's where that Weber test, that Rene test comes in, the audiogram, tympanogram. We'll talk about getting an MRI. So these are all diagnostic tools that we can associate with the way the patient is presenting to determine that they have sensory neural hearing loss. All right, so getting back into the Weber test. So remember, in conductive hearing loss, when performing the Weber test, the sound is going to lateralize or be louder in the right ear. So that is conductive hearing loss. Conductive hearing loss. In sensory neural hearing loss, the sound is going to lateralize to the unaffected ear. So if a patient presents to you with right ear hearing loss and you perform a Weber test, they're going to say, I hear it louder on the left in the left ear. So I'm not confusing you guys. I'm a patient presenting with right ear hearing loss. A Weber test is performed on me, and I hear it louder in the left ear. I hear the sound louder in the left ear. That's a positive Weber. Any questions on that? Okay. For the Rene test, so air conduction is going to be greater than bone conduction. So the ear in its natural state conducts air quicker, better than bone conduction, i.e. just you hearing my voice. So this is the natural state of the ear. So we know that it's not dysfunction in the middle ear, it's not dysfunction in the external ear, the dysfunction is in the inner ear, something going on with the cochlea or the nerve tracts where those nerves are not transmitting sound to the brain. Because remember, the nerves are connected to the brainstem. And then we can also use the audiogram, tympanogram. Addition here is that MRI. Yes, sir?
So you're saying the Renee's test will be normal?
Yes, I am. Mm-hmm. Does that make sense? Okay. So audiogram, we can use a tympanogram. In addition here, we can use a MRI with or with contrast. So the reason for that is because we don't need an MRI necessarily to determine external ear pathology. Sometimes for middle ear pathology, but specifically if it's a sensory neural hearing loss, the defect is in the cochlea or the nerves. The only way we can tell is using an MRI. Like we can see, is it a mass? Sometimes we can get a CT, but ideally with contrast, it's going to illuminate better. And again, this is like this is otolaryngology stuff. That acoustic neuroma, for example, will illuminate better on an MRI. Because a CT is more for bone, a diagnostic tool for bone, whereas an MRI, that acoustic neuroma is a mass built up from that myelin sheath. So that's why that MRI will be a better diagnostic tool for us. So presbycusis dip. This is the most common cause of sensory neural hearing loss. Yes, it is. So this is an example of, this is an audiogram here. Ideally, typically, you will see that dip at the 2,000 to 8,000 frequency range. Is usually in conjunction, so together, but that doesn't always mean like the patient is gonna have 40 decibels of hearing loss on the right and 40 decibels of hearing loss on the left. It could be 35 and 40. It could be 20 and 40, right? So it's not always gonna be equal necessarily, but typically in presbycusis, it is equal bilateral hearing loss. Most common, sensory neural hearing loss. So this is just an example. And you guys won't be required to read an audiogram on the test. I might give you an audiogram as a clue or a hint to help you with the vignette question, but you won't be like required to read audiograms or tympanograms. That's not within our practice. Now, if you become a ENTPA, absolutely, you will, but not like for family medicine. So for neural treatment, remember, if possible, we can treat the causative region. So remember, if it's that multiple sclerosis or if they have a neuropathy, like that auditory neuropathy. So it's just going to depend on the cause of the sensory neural hearing loss, of the neural hearing loss. Treatment for sensory hearing loss. So remember, we're in the cochlea. So the deterioration specifically of the cochlea is not, there is no treatment for that. So we can't like do a cochlear transplant and the patient's hearing be restored. So just know that it is no definitive treatment for sensory hearing loss, because that's specifically in the deterioration of the cochlea. One of the things we can do is really harp on them on the prevention and the progression of hearing loss. So hearing protection, maybe not listening to music as loud, maybe not if they are exposed to loud noises, air traffic controller, maybe they need to retire, change jobs. So prevention is key with sensory hearing loss. One exception is the sudden sensory neural hearing loss. We'll talk about this in a second. And then I kind of already talked about, we can do hearing aids if they have a speech discrimination score of what? What is the normal range for a speech discrimination score? 90 to 100. If they have less than 90 on their speech discrimination test, it's of no benefit to refer them for a hearing aid. They're just going to hear that sound even more muffled. All right, so sudden sensory neural hearing loss, quick clinical presentation. So patients, sometimes this presents unilaterally, bilaterally, most commonly unilaterally within 72 hours. So this is a patient presenting to clinic saying, yeah, I just can't hear out of my ear. I haven't been exposed to, you check all the boxes. You're asking any recent travel, are you diving, any explosions, have you potentially perforated your TM, were you using a Q-tip to clean? So you get all of those questions out to the patient. They say no. Causes of sudden sensory neural hearing loss, generally is idiopathic. We don't know exactly what's the cause. That's the most common. It can be secondary to like a virus or an autoimmune disease, but generally it's something that happens and that can be treated and resolved, unlike sensory neural hearing loss. We can treat sudden sensory neural hearing loss. So diagnosis, so we'll get an audiogram. If you see that change of 30 decibels or more affecting 3 continuous frequencies, that's your key that the patient likely has a sensory neural hearing loss. Also associated with hearing loss within 72 hours. So this is like very acute, very quick. We'll also get a MRI just to assess the cochlea. And then treatment for sudden sensory neural hearing loss is corticosteroids, so prednisone. It can be oral or intratympanic. We can prescribe oral prednisone. We will not be doing like intratympanic injections into the TM. So we may need to refer them out to ENT. Biggest thing here is do not delay prescribing the patient oral steroids, because you can prescribe them oral steroids and then take it away to say discontinue after you get the results from the audiogram or from the tympanogram. All right, can I get a volunteer for this question? To read this question?
A 73-year-old male presents to his primary care provider complaining of decreased hearing over the last several years. His wife complains that he has to turn the television up louder and doesn't hear her when she tells him to take out the garbage. Physical examination reveals AC greater than BC bilaterally and Weber is midline. Which of the following is the most likely diagnosis?
All right, so what from this vignette clues you in that the patient is having some hearing loss aside from complaining of decreased hearing? Right, so anybody? He's old, yeah, he is old, 73. Anything else? Increased volume, yes. Is that an appropriate Renee test for this patient? Right? Okay. Weber is midline, AC is greater than BC. So which of the following is the most likely diagnosis? Are we thinking cerumen impaction? Why not? Weber is midline, AC is greater than BC. Also remember that cerumen impaction, the hearing loss is going to be some pathology in the external auditory canal or middle ear. At this point, with that bilateral hearing loss, we're in the cochlea, we're in the inner ear, sensory neuron. We'll skip B. Going to otosclerosis. So we haven't talked about this much, but I'll just kind of walk you guys through it. So otosclerosis, again, that's middle ear pathology. Those are the ossicular chain bones, right? So that stapes or stapes is not moving correctly. Think about it like arthritis in the bones within the ear, right? So because you can have arthritis in the knee and the shoulder, so you can also have arthritis in the bones within the ear. So we know it's not that. Sudden sensory neural hearing loss. Why do we not think it's D?
It's been over the last 7 years.
Absolutely, it's progressive. And then Meniere's syndrome, we'll kind of talk about, this is like absolutely not a presentation of Meniere's syndrome, like they don't have any vertigo or any history of Meniere. So we'll talk about that in further lectures. But our answer is the presbycusis. Any questions on that? All right, tinnitus. So this is the presence of sound in the absence of a sound source. Usually it's associated with patients that have increased age or hearing loss, like sensory hearing loss or sensory neural hearing loss. Symptoms, so patients can describe this very differently. Ringing, popping, clicking, pulsing, blowing, hissing, buzzing. It's just a sound. I don't know how to describe it, but it's constantly, it's there and then it dissipates. Like, they will describe it differently. The pathology, the pathophysiology of this is not really understood a lot. What is thought is the damaged hair cells inside the hair inside the cochlea it becomes damaged, and that leads to an eliciting sound. And it's not consistent. Like, it can come and go away. It's not always like once patients has tinnitus, it can be associated with being exposed to louder sounds that can cause this. Like, so just know that it can present in these different forms, but the pathophysiology is not well understood. All right, evaluation of tinnitus. So this is a very important slide. And this is going to help you in further lectures understand the workup of how the patient is presenting. So for evaluation, so a patient comes in and they tell you they have buzzing, clicking, popping, ringing, only unilaterally in one ear. If they have it bilaterally, or if they have bilateral hearing loss, they can have these in conjunction with each other. We need to get an audiogram if they don't have an audiogram. I see some smirks and smiles. Does that make sense? Okay. So, unilateral tinnitus, bilateral tinnitus, or bilateral hearing loss associated with tinnitus, right? Yeah.
With that, is you talk about the audiogram, is it, have an audiogram within the span of development tinnitus, or do you want one, like, they have one 6 months ago, they developed tinnitus, 3 months later, you want one after tinnitus develops?
If they don't have an audiogram on file, then that's when you'll get an audiogram. I would say, just stepping out of academia for a second, if they've had an audiogram within the last 6 months, you're probably okay not to get an audiogram. The way that the exam is formulated, like I have to let you know what the audiogram says, or hey, they do not have an audiogram. If the question does not say that the patient has conducted an audiogram, they do not have an audiogram. So don't input information in the vignette. If it's not there, it's not there. Does that make sense? Okay, now that's for an audiogram evaluation. So for an MRI, so the primary diagnostic modality for patients with unilateral hearing loss, so remember we talked about that acoustic neuroma, plus or minus tinnitus. Because they can have tinnitus with an acoustic neuroma or unilateral hearing loss. They may not have it. So plus or minus tinnitus. Key here, if they have unilateral hearing loss, then we're going to get an MRI. And again, kind of going into the test, I have to let you know, has the patient had an audiogram? Or give you an audiogram and say, this is a normal audiogram. What's the next best step? An MRI to assess this patient.
Ma'am?
Yes, sir.
But this is after we've ruled out conductive hearing loss?
Yes, we're in sensory
Okay,
neuro.
so
Yep.
okay.
And I'll be honest, you can have tinnitus and conductive hearing loss or sensory neural hearing loss. But the patient is going to present to you with hearing loss and associated symptoms. So if you know, okay, this patient has unilateral hearing loss, you don't know if it's sensory neural, you don't know if it's conductive hearing loss, you just know this patient has hearing loss. So because the patient has unilateral hearing loss, if they already have an audiogram, your next step is to get an MRI. Because you have to assess what's going on with the patient. Does that make sense?
So, but you're not necessarily going to step to like a tympanogram or something like that to rule out conductive on your way to MRI?
You can perform, usually audiogram and tympanogram are performed synonymously or simultaneously. So, and again, I have to give you that information. Just to be transparent, like I said, tympanograms is out of our scope as a PA. Like we are not going to perform tympanograms unless you work. Is it any National Guard in here? Like National Guard? So yeah, like if you go into ENT or otolaryngology, become a PA, you might work more with tympanometry, but for family medicine, military treatment facilities, at least for Army, yeah, that's like all audiology and otolaryngology.
So we won't necessarily be ordering this MRI, we'll have to refer them out at this point to.
You can order an MRI, and a couple things you can do depending on how the patient presents, right? So in the vignette, just remember I have to give you the information. The next step could be, what's the next best step? Refer to otolaryngology and order an MRI of the right ear. Refer to radiology for an MRI, right? If they already have an audiogram, you don't want to refer them for another audiogram. Perform irrigation. That's like of no use, right? So like that kind of thing. So just kind of walking through, but you will have the information on the test where it's like, do they have an audiogram? Do they have a tympanogram? Is their Weber or Ryan normal? But you're responsible for interpreting some of those results. It's not the audiogram or tympanogram, the Weber and Ryan test. So you will not be required to interpret a tympanogram or an audiogram. That is way out of our scope as a primary care unit. All right, and then the primary diagnostic modality for patients with pulsatile tinnitus, so they might describe it as hearing their own heartbeat. We want to rule out any vascular lesions or sigmoid sinus abnormality, and we'll talk about this in a later lecture. That's where a clot develops in the sigmoid sinus. We need to assess the arteries in the vessel, in the veins, and the only way we can do that is through an MRA or MRB. Treatment, so really it's just prevention, avoiding excessive noise, hearing protection, avoiding ototoxic agents. Some ciprofloxacin does have some ototoxicity, but it's a lot less than like gentamicin or neomycin. Masking, so using white noise hearing aid. So emotional distress, this can affect patients' quality of life. So prescribing them, so stepping out of academia, no, I would not prescribe the patient antidepressants for tinnitus. But I've seen it done, and if you do decide to do that, just note and explain to the patient that this is not going to treat the tinnitus. It's literally to help with your quality of life. Because maybe they have some other things going on that requires antidepressants, but I'm not going to solely treat tinnitus with antidepressants. But you can do it. Habituation techniques and cognitive behavioral therapy, retraining. It's some newer treatments like a transcranial magnetic stimulation, implantable brain stimulators. Like that stuff is like referred to HEENT, and they have to determine even if the patient is a candidate for these advanced procedures. So hyperacusis, excessive sensitivity to sound, may be present in patients with normal hearing or with decreased hearing. So causes for patients with normal hearing, so we do an audiogram, their audiogram comes back normal, perhaps their Weber-Rhine test is normal as well, but that doesn't mean that they don't have hyperacusis or a higher sensitivity to sound. Some causes, autoimmune disease, noise, trauma, migraines, it could be psychological too. Causes for patients with hearing loss or cochlear dysfunction, so it's referred to as recruitment. So this is where we have to really ask the questions and get into the HPI. Do you only have sensitivity to louder sounds, or do you have decreased sensitivity to softer sounds? Like really asking those questions. Physical examination likely will be unremarkable. Patients may have some abnormality if they have hearing loss. But remember, with hyperacusis, patients can have normal hearing or they can have hearing loss. Imaging, none is required for this diagnosis. For treatment for normal hearing patients, we can do habituation training, earplugs, in noisy environments. And then for cochlear dysfunction, so hearing aids can be used as, hearing aids are, I think this is the cochlear, the compression circuit. So hearing aids can amplify sound if they have the correct speech discrimination score, or the circuits can compress sound. So if they hear a sound too loudly, then it can compress it as well. So that is one of the benefits of a hearing aid with patients who have cochlear dysfunction. All right, can I get a volunteer for this question?
A 45-year-old factory worker presents to his primary care provider with decreased hearing bilaterally, but worse on the left side. He states it has gradually been getting worse, and now he hears his heartbeat in his left ear. He works in a machine shop around loud noises and does not always wear hearing protection. An order for an audiogram is placed. What other testing does this patient require?
What are we thinking? And what's the reason, or our reason for going with A? Yes, the pulsatile tinnitus. Absolutely. All right, any questions on the information that we covered today? And I'll stand up here later if, for a few minutes if you guys have questions I want to ask in front of the group, but I'll be up here. I think our next, what is your first test? Or have you had your first test? Farm on Monday, and then you have my test, Pat, and then I think I'm the Monday after. Ooh, okay, so you guys get like some practice. Okay, perfect, that's good. Okay, I'll be up here for any questions. If you do need to reach out to me, Canvas is probably